Welcome to the ANNA newly updated CKD modules that address nursing care of the patient with CKD in any setting. I am Leslie Dinwiddie, project leader for these modules. This evening, it is my great privilege to introduce our author and presenter of the fifth module, Kidney Replacement Therapy Transplantation. Amy is the Living Donor Coordinator for kidney and liver transplants at the University of North Carolina in Chapel Hill. In addition to her work with these modules, Amy is an author for the ANNA core curriculum and is the chair designate for ANNA's Transplant Special Practice Network.
Thank you, Leslie, and good evening, everybody. As Leslie indicated, I'll be presenting the module regarding transplantation. These modules are dedicated to the memory of a past president for ANNA, Sally Burroughs Hudson. She was a fierce proponent of continuing education for all nurses. And as we said, this is CKD Module 5, Kidney Replacement Therapy Transplantation. So the objectives for our webinar tonight are that the learner will be able to explain why kidney transplant has the best patient outcomes for the suitable patient with kidney failure, list the different types of kidney donors, discuss the kidney transplant evaluation process, describe the surgical and post-operative procedure for both living donor and recipient, and outline the long-term treatment for the recipient. The first successful transplant was performed in 1954 at the Brigham Hospital in Boston. The donor and recipient were identical twins, one of whom had severe kidney disease. The transplant was successful because they were identical twins sharing the same tissue type. Thus, the potential for organ rejection was significantly reduced. Prior attempts at kidney transplant had not been successful due to organ rejection. At that point, there was little to no knowledge and understanding about the significance of tissue typing and matching in order to avoid the immune system's response to a foreign body, such as the transplanted kidney. So surgeon Peter Medawar and his colleagues conducted research using chickens to elicit the effects of the body's immune response and the physiology of transplanted tissue rejection. Excuse me. Their research led to a better understanding of the human immune response and tissue rejection, and they actually received a Nobel Prize for medicine in 1960 for this work. Today, the biological relationship of the donor and the recipient is not nearly as important due to the creation of powerful immunosuppressive medications, which are usually able to prevent rejection. These medications have therefore allowed us to have successful long-term transplantation of hundreds of thousands of patients with kidney failure. In 2019, an executive order to increase kidney donation for transplantation, and in 2020, CMS final rule changes were charged us to do so. So to illustrate our history and where we are today, we have the data. The United States Renal Data System is a great, reliable source for data about the demographics and the care of our CKD patients, including those with kidney failure who are receiving some sort of kidney replacement therapy. As you can see on this graph, the prevalence of kidney failure is on the rise. And notice while the majority of kidney failure patients were on dialysis at the end of 2021, almost 1/3 of the total prevalent population was successfully transplanted. Which is a testimony to the superiority of this therapy. The total number of prevalent population reflecting all the patients receiving kidney replacement therapy on the last day of 2020 was over 808,000. And between 2001 and 2021, the count of individuals receiving hemodialysis nearly doubled to over 462,000. However, this 2021 total represents a decrease of about 3% from the peak of over 492,000 people in 2019. So comparative mortality and survival, this becomes evident when we review this most recent data between dialysis and transplant. The overall mortality rate is more than 3 times higher for patients on dialysis compared to those with transplants. Mortality rates after 1 year of dialysis are around 20 to 25%, and at 5 years, survival rate is around 35%. Whereas people that receive a kidney transplant have a 3% mortality rate after 5 years. So why are we not transplanting more patients? The answer is pretty complex, but a simplified version of it is that there are not enough kidney donors, living or deceased, to meet the demand. The recent data from UNOS shows us that as of March 11th of this year, there were over 88,000 people, both adults and children, on the kidney transplant waiting list for a kidney from a deceased donor. And remember that number as we go to the next slide. Only some 27,000 patients were fortunate enough to get a kidney, less than 1 in 5 of those waiting. And this is not a new problem. Between the years of 2017 and 2023, there have been some 122,000 deceased donor transplants and almost 43,000 living donor transplants performed in the US. That volume is growing every year. However, this tells us that the donor numbers are not sufficient to meet the demand, which reinforces that the donor approach process, particularly with deceased donors, must be done in a very sensitive fashion and, of course, in accordance with the law. We know that all of us and our loved ones are potential donors, living or deceased. Still, many healthcare workers, along with the general public, are not aware of the huge disparity between the number of kidneys donated and the number needed. There's also some myths about organ donation that really need to be exposed if we're to increase the numbers of deceased donors. For example, one myth is that when organs are removed, the donor's body is mutilated, making an open casket viewing impossible. The truth is, organ recovery is performed as an actual surgical procedure. Therefore, the body's integrity is preserved and open casket viewing is possible at a funeral service. Another myth is that the elderly cannot donate their organs. In fact, organ donation can be done at any age. The donor's medical condition will be assessed at the time of death to determine the suitability for organ donation. Another very sad myth is that if you are an organ donor, medical efforts will not be made to save your life. Not true. All efforts are made to save a donor's life in the hospital. In several states, one has to volunteer to be an organ donor, or the donor's family member has to give permission for actual organ donation. Finally, there is a myth that rich and famous people are considered priority recipients for organ donation, but the truth is a recipient's opportunity for an organ is based on their blood type, waiting time on the transplant list, and overall medical condition. So as we've shown, there's over 100,000 kidney failure patients hoping for a transplant because transplant has outcomes far superior to dialysis. These superior outcomes are because the transplanted kidney functions as a normal kidney. So there's usually no need for further dialysis once the kidney is fully functional and the patient regains all the other benefits of kidney function, which dialysis cannot replace. They have more energy. They're able to adhere to a regular diet with regards to their kidney function. They have normal fluid volume, so there aren't fluid restrictions, and they're able to resume what we call a more normal lifestyle. Kidney transplant is very complex, and that complexity is increased because successful transplant involves not just one patient, but two, the donor and the recipient. It takes an interdisciplinary team of experts working with both patients to make the transplant happen. And a process begins with intensive evaluation. This slide depicts broad categories of patient dimensions that must be evaluated for both living donors and recipients prior to transplant. The order is not indicative of priority or timeline, but all these dimensions must be considered in order to assemble a holistic assessment. A patient's cultural and religious beliefs can determine how they view illness and treatment. It's important to ascertain any cultural beliefs that might have a negative impact on the transplant process. We want to know their health literacy and their level of education so that we can educate them to make an informed give informed consent and informed decision. We need to make sure that they have social support in place, that there is financial support or resources that they have for the costs that will come to them with new medications and multiple visits to clinics and laboratories for follow-up testing. There's also a psychological and psychiatric component to an evaluation of both the donor and a recipient. There's a nutritional and a pharmaceutical assessment of both the donor and the recipient. Medical and nursing, as well as surgical input, is also part of the interdisciplinary team. So as we've already seen, donors are the rate limiting factor in this life-enhancing and preserving therapy. There are a few different categories of kidney donors. The largest category, as seen in the UNOS data, is that of a deceased donor. So a deceased donor is a person that has died, and their organs can be used, specifically kidneys, for donation. A directed donation is also something that can happen with deceased donors, is that the family of the deceased donor may direct that kidney to a specific recipient who is on a wait list. For instance, if I knew of a friend on the wait list and something were to happen to me, my husband knows that I want my kidney directed to this person that I know who is on the wait list. That's considered a directed donation. Then, of course, we have living kidney donors. There can be living related donors, a donation from a family member. There can be living unrelated donors, meaning a donation from an individual who's not related by blood. It could be a spouse, it could be a friend, it could be a coworker, a church member. We see all sorts of people come forward to be kidney donors. And then there's an option of non-directed living donation. So a non-directed kidney donation is from an anonymous living donor. They're sometimes called altruistic donors. Sometimes we have people contact the transplant center. They have learned about kidney donation as a living person through research or something they've seen on social media, and they decide that they're interested in seeing if they can help someone, but they don't know anyone specific with kidney disease, so they may come forward to be a non-directed or an altruistic donor. PHS, increased risk donors. PHS stands for Public Health Service. This is a category of donors that is defined as anyone meeting one or more of the following criteria in the last 12 months. And you may find that this sounds a little similar to questions that are asked if you do go to donate blood. So there is some overlap there, but in organ donation, if anyone has met any of these criteria in the last 12 months, they're considered increased risk. Sex with a known HIV, hepatitis B, or hepatitis C positive person, men who've had sex with men, people who've had sex for money or drugs, if they've been in jail or prison in the last 12 months, if they've recently been diagnosed with a sexually transmitted infection, if they're a child born to an HIV or hepatitis B positive infected mother, if they use IV drugs or they have sex with a person using IV drugs, or if they themselves are on hemodialysis. This classifies them as a PHS increased risk donor. Additional testing is done for these donors to make sure that they are not positive for HIV or hepatitis B or hepatitis C. And if they are, those kidneys are placed accordingly to people who are agreeable to receive a kidney from one of these donors. So a hepatitis C positive donor years ago may not have likely been used for organ donation, but nowadays, because there is medication to treat and cure hepatitis C, we are finding that we do accept kidneys from donors who are hepatitis C positive. So patients can choose to receive a kidney from a known hepatitis C positive donor, even if they themselves are not hepatitis C positive. It could shorten their wait time on the transplant list because not everybody on the list is interested in taking a kidney from a hepatitis C donor. It does require informed consent from the patient. This is something that's usually obtained in advance, asking if they would be willing to consider a kidney from a hepatitis C donor if one were to become available. And their listing criteria is modified to reflect that decision if it is yes. And so when a hepatitis C positive donor kidney becomes available, it's only offered to people that have given consent that they would be willing to consider it. There's close monitoring of a person's labs after receiving a kidney from hepatitis C donor. And if they do convert to a positive hepatitis C antibody, then treatment is initiated. So let's talk about living donors. Living donors provide the best and the quickest transplant for patients. A living donor goes through a very thorough medical evaluation, psychosocial evaluation, to make sure that they are, one, healthy enough to safely donate, because it is a major surgery and it's not a surgery they need for their own health. And also to make sure that their kidney function is sufficient that if they give up one kidney, the kidney they are left with will maintain them for their lifetime. So it is quite a thorough evaluation. Living donors are usually family members or close friends with the patient, but as the years have gone on, we've really seen that expand, not only with non-directed donors, but with people who just happen to read on social media that someone was in need of a kidney by name of Sally Jones or whatever the name may be at UNC or any other center, and they contact the center and say they'd like to see if they can be a donor for them. So it really has broadened over my years in transplant as to how many non-family members and close friends do come forward to be potential donors. If we find that the living donor and the person they wish to donate to are not compatible, meaning their blood types are not compatible or their tissue typing is not compatible, then we can offer them options such as desensitization or kidney exchange. And sometimes kidney exchange is referred to as a kidney swap. Desensitization is a treatment or a series of different treatments that are used to help remove blood type antibodies in the recipient before and after the transplant. Plasmapheresis and possibly IVIG infusions are used to treat the recipient in the days leading up to and the days after the transplant to sort of trick their immune system into not recognizing that the kidney they received is from a different blood type. At my center and in my experience, those recipients have gone on to have as successful outcomes as if it were a blood type compatible transplant. So this is very successful when it works. There's lots of lab work and additional studies that are done during this desensitization phase to make sure that those pheresis treatments and IVIG are working, or else we can't safely go forward. But if those processes are working, we have been able to successfully transplant patients with an incompatible blood type. The other option that I mentioned, the paired exchange or swap, is when there's living donors unable to donate the kidney to their selected recipient because of incompatible blood types or tissue typing, and we find another pair in a similar situation that they can swap with. So here's a diagram explaining how that might work. So this diagram shows Mary and Lucy, the donor recipient pair on the top of the slide. They have incompatible blood types. Mary is a willing donor who is blood type A. And Lucy, her friend, the hopeful recipient, is blood type B. The donor and recipient pair on the bottom of the slide is our sisters Kara and Josie. Kara is a potential donor that has blood type B, and Josie, who needs a transplant, is blood type A. Since Mary and Josie both have blood type A and Lucy and Josie both have blood type B, Mary can donate to Josie while Kara can simultaneously donate to Lucy. So this is a swap or an exchange. You may have seen in the media where there have been multiple simultaneous swaps at multiple centers at the same time, and that is quite a large undertaking. Lots of complexity, lots of coordination, but those can happen. And this is an option that has been available in the last 10 to 15 years and has really taken off as something that a lot of pairs do enroll in if they are found not to be compatible with their intended recipient. So like I said earlier, a potential living donor goes through a thorough evaluation. Specifically, they start by talking with an independent donor advocate or an independent living donor advocate. You may see that abbreviated ILDA. This is something that is required by law that donors have. It is someone who is not employed by or affiliated with the actual transplant department or the transplant recipients in any way. But they are knowledgeable and trained in living donation. And so they serve as the patient or the donor's advocate in the whole process. They assure the donor that their procedure is completely elective and voluntary. They explain that there are physical risks in not only the testing, but the surgery. And then after donation, living with one kidney. It is not risk-free. So we tell them from the very beginning that this is something that they really need to keep in mind and consider when making their decision. There's also a thorough psychosocial assessment. There's a thorough medical, physical assessment. And all of these things are taken into account when determining if this person can safely undergo living donor surgery. Of course, there are also some contraindications that come up that rule people out as potential donors, and those can vary from center to center. But you'll find that most centers do have some commonalities in those contraindications. At this time at my center, someone who is a type 1 or 2 diabetic cannot be a living donor because that is a leading cause of kidney disease itself. So we want them to keep both their kidneys. If they have certain autoimmune disorders, such as rheumatoid arthritis, that does rule them out. If they are markedly obese, and that does fluctuate from center to center and is usually determined by the surgical team as to what BMI is acceptable. So those are things that are contraindications for someone to be a living donor. Some of those things are modifiable, such as their weight or BMI, but some things rule them out completely as a potential donor. The potential recipient who is in need of the transplant also must undergo a thorough evaluation. All Medicare kidney failure patients are entitled to a transplant evaluation. The best way to describe this is every patient who is in kidney failure should be considered by their primary nephrologist and team as to whether or not a transplant evaluation is suitable for them. Sometimes there are comorbidities that prevent the patient from being referred to an actual transplant center because the primary nephrologist can make the determination that they are not a suitable transplant candidate. If there's anything that is questionable about whether or not they're a suitable candidate, then we do encourage nephrology practices to go ahead and refer those patients to us. But for instance, an example may be a 90-year-old person on dialysis who has cardiovascular disease and other chronic conditions. Obviously, they would be too risky to undergo an elective surgery. So that's someone that would not necessarily be referred to the transplant center, but their local nephrologist could make that decision that transplant is not an option for them. But it is something that should be considered for every patient. We do encourage preemptive transplant, and that's where we do a transplant before someone reaches the need for dialysis. We encourage nephrologists and local doctors to refer patients for transplant consideration once their GFR or creatinine clearance reaches a level of 20 or less, sometimes 21 or 22, so that we can begin this process prior to them needing dialysis, especially if they have an option of a living donor. There's been many times where we've been able to successfully evaluate a recipient, evaluate their living donor, and proceed with the actual transplant before that person ever needs dialysis. And that would be an ideal situation, and that's called a preemptive transplant. The evaluation of the recipient, the goal is to make sure that they are suitable to be transplanted, and that is reached on an individual basis. The interdisciplinary team is who's involved with that decision and that evaluation. And as I've mentioned before, it includes medical, psychosocial, financial considerations, their ability to self-manage their care afterwards or have an adequate caregiver, and how well they can understand their health literacy and make sure that they can make an informed decision about proceeding with transplant. We also educate recipients about outcomes of not only our center, but the national outcomes and what the averages are, and make sure that they understand and are able to set reasonable expectations after transplant. Because every living donation kidney transplant involves 2 patients, scheduling and timing of the surgeries can be complex. Once the donor and recipient evaluations are complete, the surgeries are scheduled. The day of the procedure, the donor is taken to the operating room first, where he or she receives anesthesia and is positioned laterally for removal of the kidney. As illustrated on this screen, the majority of donor nephrectomies are done laparoscopically, with the donor in this jackknifed position. The procedure will convert to an open surgery in a rare case if there's any intraoperative emergency, such as bleeding. With time communication between the donor room and the recipient room, the recipient is brought to another operating room where he or she receives anesthesia, and the procedure commences with making a 3 to 5 inch groin pocket incision where the donor kidney will be placed. Now, the native kidneys, the deceased kidneys in the recipient, are not usually removed. They are higher up in the body and are not in the way when placing the new transplanted kidney. So we don't take out the deceased kidneys at the time of transplant. That's how we practice at my center, and I would say a majority of centers. If a patient has a condition in which we think their native kidneys do need to be removed, an example that pops to mind is polycystic kidney disease. Those kidneys can get quite large, and if they are very large, can really impact the space available within the abdomen. So that is where we may find that our surgeons plan a native nephrectomy on this person prior to a planned transplant, maybe 3 months before, so that there's no impact as far as room in the abdomen to place the new kidney. But at our center and at most centers, we do not do any native nephrectomies at the time of putting in the transplant. The donor kidney is brought from the donor room to the recipient room and placed inside the recipient. The blood vessels of the transplanted kidney are sewn to those of the recipient, and the ureter is attached to the bladder. And so the recipient will urinate after transplant as they do before. Soon after the anastomosis of the blood vessels and the ureter, we can sometimes see that kidney start to produce urine right away. Each procedure for a transplant can last anywhere from 3 to 5 hours. The donor procedure starts just a little bit earlier, and it does certainly finish a little sooner. And the living donor usually does stay in the hospital for about 2 or 3 days after surgery. So the process for the deceased donor is a little different. The surgical procedure for removing the kidney from a deceased donor is just a little more complex. The deceased donor organ donation process begins, hopefully when that person is still alive and they've made it clear on either their driver's license or on a state donor registry or with their loved ones that in the event of their death, they wish to be an organ donor. In that case, in the case that they are hospitalized in grave condition and imminent brain or cardiac death is on the horizon, then an assessment for organ viability can be conducted. The organ procurement team that's on site at the facility will assess the donor's health history and lifestyle based on talking with their family members and looking over medical records. And if the organs are suitable, then the OPTN begins the selection for finding a recipient in the area, if they can, and based on several other factors that these kidneys or organs would be well matched to. Once those plans are in place, the donor is taken to the operating room and for organ recovery. Different organs that are donated from a deceased person have a different timeline as to how quickly they need to be transplanted into a recipient from the time they're removed from the donor. Things like hearts and lungs have a shorter window of viability, so it needs to happen rather quickly. Livers, not quite as short a time as hearts and lungs, but still a relatively short window of time. Kidneys can be transplanted anywhere from 24 to 48 hours post removal from the donor. Now, the preference of most transplant surgeons and centers is to get that kidney transplanted into the recipient in under 24 hours from the time it was removed from the donor. But we do have the ability to go a little longer if necessary, because sometimes deceased donor kidneys are not coming from the hospital in the next town or the next county, but they may be coming from a different state or from all the way across the country. So there's logistics and travel time and things such as that. So we're fortunate that there is that amount of time that we can work with when talking about transplanting kidneys. So the recipient, the person that receives the transplant, they stay in the hospital for about 3 to 5 days after the surgery, and their overall status is monitored with close attention being paid to their urine output, their response to the immunosuppressive medications. Kidney patients tend to have postoperative pain for about a week. They can describe feelings of tugging or stinging pain that may remain around the incision a little longer than a week. And that's as is developing as adhesions are forming in their body from where the scar is. Most patients don't require narcotics for pain after the first week or two, or if at all. This, of course, assumes that they have a normal postoperative course without any short-term complications. Complications that may occur soon after the transplant surgery include clots or kinking in the renal artery or vein, or they could have an obstruction or stricture or leaking associated with the ureter. More detailed information about these short-term anatomical complications can be found in the referenced ANNA core curriculum, chapter 21. Infection or bleeding may also occur as a post-op complication, as well as early rejection. Any sudden decrease in urine output, an increase in abdominal pain or swelling, sudden changes in their blood pressure or fever should be reported immediately to the transplant team so that they can be assessed and treated. Immunosuppression is, the goal of immunosuppression is to modify the immune system sufficiently in order to prevent rejection, but not so much as to allow infections, malignancies, and other side effects. So it's quite a fine line we're writing there with our immediate postoperative period with the kidney transplant recipient. In spite of incredible advances, most immunosuppressants are not specific to the organ transplant rejection response. The net effect of most immunosuppressants is an overall suppression of the immune system, and that leads to an unfortunate increase in bacterial and viral infections, as well as certain types of cancers. So we start with induction therapy, sort of a blast of immunosuppressive medications at the time of transplant. And the goal for that induction therapy is to decrease the T-cell response to the new graft. There are a couple of different medications that are used for induction, polyclonal antibody preparations as well as monoclonal antibody preparations. The polyclonal ones, ATG, ATGAM, the monoclonal ones could be basiliximab or Campath. And then there are immunosuppressive medications that we use to treat acute rejection and we consider as rescue agents. when we note that there is rejection, these are drugs that we give high doses of to rescue that kidney from a rejection that can't be stopped. So they're very similar to some of the induction therapies that we use. Some of those include IVIG, which I mentioned is used in desensitization, and also rituximab. Routine early post-op management addresses all the risks of any intra-abdominal surgery performed under general anesthesia. So we want to maintain circulatory function. We want to make sure that any arteriovenous access for hemodialysis is staying patent, because we may need to use that access. We also want to assess leg pulses on the side of the transplant. If you recall on a few slides back where you see the incision is made and the kidney is tucked sort of just inside the hip bone area on either the right or the left side. The vessels that are used to supply blood to where that kidney is placed are the same blood vessels that supply blood to that leg. So we want to make sure that we've not impacted that blood flow or sacrifice that blood flow to make blood flow to the kidney work. So we need to make sure that those leg pulses are checked regularly. We want to maintain pulmonary function. Pulmonary toilets and early ambulation are essential to prevent both lung infection and DVTs. We want to make sure that we're monitoring their fluid and electrolyte balances with lab work. We're preventing infection with antibiotics, and make sure that we're administering pain medication as needed, so that we can keep them in a state where they will be willing to get up and move around and be active, because that is also going to help them heal a little quicker and get out of the hospital sooner. Kidney transplant is by far the superior kidney replacement therapy in terms of both quantity and quality of life, because of the return of normal kidney function. Still, a kidney transplant is not a cure. Because the transplanted kidney is a foreign tissue, it will require lifelong immunosuppression medication, which starts with very high dosing. This puts an already at-risk patient for infection at even higher risk. So in caring for these patients, we walk a very fine line between infection and rejection. Careful hand washing before and after patient contact is critical for all staff, visitors. Modified protective isolation is recommended for any recipient that has leukopenia. For all patients, strict aseptic care of IV lines, wounds, and the urinary catheter is mandatory. And as we've already said, pulmonary toilet and getting them up and moving around is strongly encouraged. We want to make sure that we're giving them adequate nutrition and they're taking in adequate nutrition for wound healing. We want to isolate them from any other infected patients. That's very important when you're talking about putting them on a hospital ward where other types of patients may be in and off on and off the unit. We're going to make sure that they're facilitating good skin hygiene, oral hygiene, and that we're administering any antivirals or antibiotics that we give prophylactically in a timely manner. Remembering that the goal of this therapy is to maintain the balance between rejection and infection, induction therapy is tapered as quickly as possible to achieve stable maintenance immunosuppression with therapeutic targets as determined by each center's protocols. The most common long-term maintenance regimen immunosuppression in the US is mycophenolate mofetil, or MMF, and it's used a lot in combination with tacrolimus. However, there are other maintenance medications that are used, such as Envarsus, Myfortic, Belatacept. Cyclosporin is still used in some patients, prednisone, and Rapamune. The next few slides will detail some of these medications, their actions, and their most common side effects. So mycophenolate mofetil is also called MMF or Celcept, or mycophenolate sodium, also called Myfortic. These are drugs that came into use in the mid-1990s, and they pretty much have replaced azathioprine or Imuran at many centers. These drugs selectively inhibit the proliferation of T and B cell lymphocytes and are mostly metabolized in the liver and eliminated by the kidney. They're commonly prescribed in combination with a calcineurin inhibitor like tacrolimus or cyclosporin or sirolimus, which also is called rapamune. Mycophenylates are administered orally every 12 hours and are administered at least 2 hours before or 1 hour after taking an antacid, such as mag oxide, calcium carbonate, or aluminum hydroxide. MMF dosing generally is 1,000 milligrams to 1,500 milligrams per day. The tablets come in either 250 or 500 milligram sizes, and a suspension is available for certain adults or for pediatrics if needed. Mycophenolate sodium or myfortic dosing is usually 1080 milligrams to 1440 milligrams per day, and they come in tablets that are 180 milligrams or 360 milligrams, and they're enteric coated tablets. Side effects of mycophenolate. Some of the side effects can include bone marrow suppression, and the skin is checked for potential squamous cell cancers. A consistently low white blood count may warrant a decrease in the mycophenolate dosage. We also watch for GI distress, as dehydration may result in stress on and possible injury to the transplanted kidney. Because it is MMF, primarily that can cause diarrhea, and the medication may be administered in doses of 250 milligrams 4 times per day. We find that decreasing the dose and increasing the frequency can help alleviate some of the GI distress. The transplant team can also suggest to alter the dose of mycophenolate to help if a patient is having ongoing diarrhea. The drug class of calcineurin inhibitors includes tacrolimus, or it's also called Prograf, which is the main immunosuppressant for many transplant centers, including my own. It is similar in action to cyclosporin, and a patient would take one or the other, but not both. Tacrolimus is used usually in combination with either steroids or a mycophenolate, but it can be used alone in some patients. There's also an extended release tacrolimus called Envarsus, and it's only taken once a day. Tacrolimus requires trough levels for appropriate dosing, and the dosing options include either a 5 milligram tablet, a 1 milligram tablet, or a 0.5 milligram tablet, or combinations thereof for oral administration. Or you can get it as an IV preparation, which is 5 milligrams per ml. Cyclosporin is rarely used now in the newly transplanted patients, but you may encounter some patients who were begun on it and have been maintained on it for many, many years. And if they're doing well, they will leave them on this medication. The most common side effect of tacrolimus are infection, just like all immunosuppressants, nephrotoxicity, hypertension, and headache, and neurotoxicity that can lead to hand tremors or a tingling sensation in the hands and feet. Now, these tremors are common with tacrolimus and are dose related. So as a patient describes these side effects, we can try to change the dosage to see if they improve. Other signs of neurotoxicity could be paresthesis, insomnia, tinnitus. They may have an increased light sensitivity. They may have some sleep disturbances or mood changes. Other potential side effects include diabetes. Although tacrolimus doesn't cause diabetes at the same rate as steroids do, but over the long term, it can certainly affect it, and over the long term, it certainly can lead to malignancies as well. Belatacept is a selective co-stimulation blocker that has been developed to improve long-term outcomes in kidney transplant recipients by providing effective immunosuppression without the toxic effects of the calcineurin inhibitors. So it selectively inhibits T cell activation, and the dosing of belatacept is an IV infusion of 10 milligrams per kilogram on post-op day 1 and 5, and then again at week 2, 4, 8, and 12. And it's infused over 30 minutes. And then beyond week 12, the IV infusion is monthly, starting at week 16, and the doses are adjusted based on the person's body weight. Now, belatacept regimen is approved for use right now only in patients who are already EBV positive because of the increased risk of post-transplant lymphoproliferative disorder, or PTLD, predominantly involving the central nervous system in EBV negative patients. So right now we only use it in EBV positive patients. Side effects of belatacept, the most common side effects: nausea and vomiting, anemia. There can be constipation or diarrhea. There can be leukopenia, and there can also be malignancies, as with a lot of the other immunosuppressive drugs. Glucocorticoids or corticosteroids add another protective dimension to the immunosuppressive regimen with their anti-inflammatory effect. They are usually a first line of treatment for rescue from a mild to moderate acute rejection, and are typically given over a short 3-day course. The determination of which medicines and doses are required will be based on that particular recipient's risk factors. All immunosuppressive medications should be given at the same time each day to obtain and maintain therapeutic blood levels. The most common glucocorticoid we use is prednisone, which is initially given through an IV as Solumedrol for induction therapy, and then orally once a day with tapering until the maintenance dose is achieved. The usual maintenance dose for prednisone is 0.2 milligrams per kilogram, but dosing can be ordered as a tapered amount and not by weight. And prednisone comes in several tablet sizes ranging from 1 milligram to 50 milligrams. Now, some transplant centers, including my own, offer steroid-free or steroid avoidance therapy after the initial doses are given. Individuals that are suitable for steroid-free or steroid avoidance are selected based on their medical status and other factors, and it can vary from patient to patient. At UNC, we are pretty strictly prednisone-free unless the patient comes in to transplant already on prednisone for another reason, then we do continue their prednisone. Prednisone can cause stomach upset. Acid blockers or PPIs can be ordered to help prevent some of those GI complications. And it can also help with some of the other immunosuppressives that cause GI problems. Nystatin swish and swallow is typically prescribed for about 30 days to prevent fungal infections. We get people up with early, wanting them to ambulate. We want it not only helps prevent DVTs, but it's important to minimize muscle weakness from steroids. And then post-transplant diabetes may occur in association with prednisone, and patients should be carefully monitored for that. Some common side effects of prednisone: this cushingoid appearance or the chubby cheeks, increased appetite, sodium or water retention, GI disturbances, peptic ulcers with bleeding. They can bruise easily. They may have impaired wound healing. They can develop acne, hyperlipidemia. These are all things that we want to make sure that we're checking for and staying on top of. Some of the less common side effects, but things that can still occur, is avascular joint necrosis or steroid-induced diabetes, cataracts, anemia, hypertension, and of course, malignancies. Sirolimus, or it's also called Rapamune, is a newer immunosuppressant, which may be used in patients who don't tolerate cyclosporin or tacrolimus. Like those drugs, it inhibits the T lymphocyte activation and proliferation, and inhibits antibody production. Sirolimus may also be used in place of Imuran, MMF, or other inhibitors to prevent nephrotoxicity. So sirolimus is usually given orally once a day. Dosing options can be from 0.5 to 2 milligram tablets, and they can be crushed, but they can't be split or cut. And there's also the option to have liquid doses mixed in that you can mix in either juice or water and take. And again, doses are adjusted based on the serum drug levels that are monitored on the patient. So some side effects of sirolimus. One of the major side effects is hyperlipidemia. Medications may be prescribed for increased cholesterol and triglyceride levels. Wound healing may also be impeded in patients taking sirolimus. So individuals who are predisposed to poor wound healing, such as diabetics, may not be candidates for sirolimus. And many times it's not our first drug of choice because of the wound healing, because people that will have a fresh surgical wound. So it may not be our first line of drug for kidney transplant patients, but it is in our arsenal to use if we can based on other criteria. In the early days of transplant, many patients did well for years, only to fall victim to immunosuppression-related cancers. Squamous cell cancer is the most common, but it's treatable. But much more serious cancers, such as solid organ tumors, lymphomas, have frequently required stopping the immunosuppression in order to treat the malignancy. So Imuran was one of the drugs that had the highest risk for malignancies, which is one of the reasons newer drugs like tacrolimus have sort of replaced Imuran. Also, several malignancies are virally mediated, such as PTLD, which is due to the Epstein-Barr virus, and squamous cell skin cancer, which is due to human papillomavirus, or HPV. We encourage all of our patients to really protect their skin, monitor their skin for any changes, protect their skin out in the sun, because the risk of malignancies, especially skin cancers, is fairly high. So in summary, the body's immune system will always recognize the transplanted kidney as non-self, and rejection of the organ will occur without adequate suppression of the immune system. And that's why the immunosuppressive medications are taken for the life of that kidney. It is essential for patients to take their immunosuppression at the same time every day. When the medications are ordered twice a day, the dosages should be as close to 12 hours apart as possible. Some of the immunosuppressives like Prograf, cyclosporin, sirolimus, they require blood trough levels. And when a blood level is drawn, like I said, to assess a trough level, it means that the patient has to hold their medication right up to the point at which they would have the blood drawn. And the intention of that is to make sure that we're seeing what their level is after about 12 hours after their last dose, right before they take the next one, so that we can determine if they are in therapeutic range or if we need to make some adjustments. All immunosuppressants cause side effects, as you've heard here, and there's a constant balancing act between maintaining the adequate immunosuppression and avoiding infections or other adverse events. So monitoring and patient education, the nursing process, they're key to effective management of immunosuppression. So, as with any medication, it's important to monitor these potential side effects regularly, and notify the team when any are identified. Many side effects can be eliminated or significantly minimized by adjusting doses or possibly changing to an alternative medication. All medicines have potential risks. Diligent teaching, monitoring, effective communication between the transplant team and the recipient can have a significant impact in achieving a positive outcome and long-term success of the kidney transplant. I can't tell you how many times being on call where we sometimes get a phone call from a patient, usually on a Friday afternoon at 3 or 4 p.m., telling us that they're out of one or more of their immunosuppressive medications. And we encourage and teach them to don't get to the point where you run out, make sure that you contact us and let us know, because we don't want there to be a gap in any of your dosages. But sometimes they call us and let us know that they've been without pills for 3 or 4 days. So they've already created a situation where they have a gap in their medication regimen and really put themselves at risk. So educating patients on the importance of sticking to a strict regimen with those medications and never running out is one of the, if not the most important factor in having a successful transplant. The most common immunosuppressants are what we've discussed here, but for details on lesser used medications such as Imuran or cyclosporin, you can see, look at the resources section in the handout for this module, and that can guide you to some more specific information about those drugs. Next, let's talk about what the patient might anticipate in life with a transplanted kidney. So there are, of course, many benefits to transplant, one of which is that we only see complication-free long-term patient for occasional checkups, if at all. We're more likely going to see those folks that are experiencing some complications. And as such, the remainder of this module is going to talk about those potential complications of the post-transplant patient. So using your nursing process, we want to recognize potential complications and report nursing assessments early to ensure timely evaluation and intervention, so that the interdisciplinary transplant team can get on top of things, make some adjustments, and treat things so that they can hopefully avoid any significant long-term risk. Remember that the patient continues to be at risk for complications of the primary disease, such as diabetes. And because they have just one functioning kidney, they, by definition, also have chronic kidney disease. Remember, too, that the prevention of rejection and infection is the focus of the post-op management for every kidney transplant patient, both in the short term and the long term. To assist you, there is an excellent resource for the nursing process, and that can be found in the most recent edition of the Nephrology Nursing Scope and Standards of Practice. Nephrology nurses use the nursing process in providing care to the patient with kidney disease, and the detailed standards on the care in this process can be found in this most recent edition of the Nephrology Nursing Scope and Standards of Practice. The evidence base for nephrology nursing guidelines of practice and process can also be found in the core curriculum for nephrology nursing, the 7th edition, which was published in 2020, and the contemporary nephrology nursing 3rd edition as well. Patient education also available that will enable the patient to partner with the interdisciplinary team and successfully self-manage his or her care. And as we know, that's part of this as well. We want the patient to be the leader of their care team and really be engaged in self-management. As with any patient education, we need to make sure we're sensitive to their health literacy and individualization of the approach to teaching the patient. Considering the patient and the family's cultural and health beliefs, preferences, and wishes are absolutely necessary. When it comes to educating the patient about long-term complications, this education needs to start from the get-go and be repeated many times, because it is something that may not come up for them for quite some time, but they need to be aware of what the signs are so that they can understand its significance. So chronic allograft nephropathy, or CAN, it's also called chronic allograft failure, CAF. These are formerly known as chronic rejection. It is the most common cause of kidney transplant failure after the first year following transplant. It is recognized by a slow, variable rate of decreasing GFR and the presence of proteinuria and or hypertension. Other causes of the graft dysfunction need to be ruled out by biopsy. And risk factors for this complication are frequently not preventable, such as delayed function, acute rejection episodes, or nephrotoxicity from the immunosuppression. But there are also preventable risk factors, such as poorly controlled diabetes and high blood pressure. The interdisciplinary team may be able to delay the progression of this chronic transplanted kidney failure by controlling the blood pressure and blood sugar a little better than the patient has been doing. They can treat the hyperlipidemia. They can prescribe ACE inhibitors or ARBs to help decrease the proteinuria. And immunosuppressive regimens may be altered, for example, to include maybe calcineurin inhibitor avoidance. And in some cases, plasmapheresis or IVIG may also be used if we're suspecting that chronic rejection is coming on. So there's lots of things in our arsenal that we can use, but most of them we need to catch things early in order to use those things in our arsenal. And like we said, some of those things are preventable by the patient and some are not. And some of these symptoms that the patient is experiencing may not be recognized by the patient, but may be recognized by their nurse coordinator or doctor who notices a change in their lab work. But the patient has to get their lab work at the prescribed interval so that we can make sure we're checking that. Someone who doesn't go get their labs for 6 to 12 months and then shows up with a GFR that's dropped to 22, maybe we could have caught something and stopped it and reversed it earlier, but we never know. So adherence to what the interdisciplinary team is recommending as far as getting lab work, taking medications, coming to clinic visits is all a vital part of making the transplant successful. So let's talk about some other long-term complications. The risk of recurrence of the original disease in the transplanted kidney. That varies based on the cause, and the prevention of recurrence must be addressed early. So certainly this is of great concern as the majority of patients have diabetes. Pancreas transplant can offer prevention of this risk for some, but at most centers that's only performed in type 1 diabetics. I know there's some centers out there that are exploring that for type 2, but again, a pancreas transplant may or may not be the solution. Strict glucose control through medication, diet, exercise are things that can help delay progression of a recurrence of diabetic nephropathy. There's gastrointestinal complications are frequent and may present as ulcers, liver disease, pancreatitis. Those are things that we need to be aware of in the long term. Ophthalmic complications are frequently a result of glucocorticoids used for immunosuppression, and they come in the form of cataracts, sometimes glaucoma, sometimes other visual disturbances. An annual eye exam is encouraged for patients. And then immunosuppression can also cause a number of other metabolic complications, hypertension, hyperparathyroidism, the Cushingoid effect that I mentioned earlier. And then there can be immunosuppression-induced diabetes that can fall into this category as well. So diabetes occurs in a moderate fraction, about 20% of patients following kidney transplant. Risk factors for developing post-transplant diabetes include age, family history, ethnicity, weight. Other comorbidities are a factor as well. Post-transplant care should include monitoring the patient for signs and symptoms, as well as doing a monthly fasting plasma glucose check if post-transplant diabetes is suspected. The fasting plasma glucose goal is to be at or below 100 milligrams per deciliter with a hemoglobin A1C of less than 5.7%. When the fasting glucose is greater than 100 but less than 125, with an associated A1C between 5.7 and 6.4, then that patient is considered pre-diabetic. Monitoring of glucose is advised if the patient's fasting glucose remains elevated on 2 or 3 separate readings. And if the fasting glucose continues to be elevated, meaning generally at or above 126, milligrams per deciliter or higher, and the patient's A1C is consistently 6.5% or higher, then the primary care provider or endocrinologist may consider starting them on oral agents or insulin. They are considered diabetic at that point. Remember, though, that agents for treating diabetes must be modified according to the kidney function that they have. And this is something that's addressed in CKD Module 3. So post-transplant chronic kidney disease is to be anticipated because a single kidney is transplanted, and so almost all patients have at least stage 2 kidney disease. We use the same management guidelines that post-transplant chronic kidney disease patients use as we do for the same stages for patients with CKD. So our module 2 of this series details the care of the early CKD patient, and you can certainly refer back to that. But as a general rule, we reduce immunosuppression whenever possible, especially if the patient has nephrotoxic, if they're on nephrotoxic calcineurin inhibitors. We also monitor for other complications of CKD, such as osteoporosis. The risk of osteoporosis is quite high due to pre-existing bone disease, secondary hyperparathyroidism, and the long-term use of glucocorticosteroids. Patients at risk should be screened with a bone density scan at baseline, and then at 6 months post-transplant, and then at intervals indicated by their risk factors. Treatments for this can include use of calcium with vitamin D supplements in patients with normal calcium, and possibly biophosphonates or calcitonin, depending on the kidney function. Weight-bearing exercises are recommended for prevention and treatment of osteoporosis. And of course, any exercise is beneficial in the treatment of preventing cardiovascular disease, which is another common complication of this patient population. The risk of cardiovascular disease in the post-transplant patient is multifactorial. It can be related to the transplant surgery itself, as in the case of high blood pressure presenting as the cardinal symptom of the transplant, renal artery stenosis. If that's present, it usually occurs 3 months to 2 years after the transplant, but it can occur later. This renal artery stenosis presents as uncontrolled high blood pressure, in spite of multiple medications, and the diagnosis is through the identification of a new bruit over the allograft. As a result of the decreased arterial inflow, the kidney dysfunction may occur, particularly after the addition of ACE inhibitors or ARBs, and the treatment is antihypertensive therapy, surgical repair, or possibly balloon angioplasty of the renal artery stenosis. In general, the data shows that high blood pressure contributes to cardiovascular disease in the general population, and the transplant recipient has the same risk as the general population, plus the risk added because of the immunosuppression medications that they're on, like the steroids or cyclosporin or tacrolimus, which also can increase blood pressure. Kidney dysfunction can increase blood pressure. Falling GFR and rising creatinine are a sign of increasing dysfunction. So the patient's adherence to their hypertensive medications is very important and must be assessed, and we have to pay attention to the patient's diet. Sodium intake is still very important, and hypertension is to be expected, but it also has to be treated. There are additional studies out there that have also shown transplant recipients have a hypercoagulable risk. Some studies have linked coagulation abnormalities to cardiovascular disease in transplant recipients. So, not surprisingly, many coag abnormalities have been linked to immunosuppressive agents. So it's important for us to be alert to any hypercoagulable state that puts the patient at risk for clots or any dysfunction. Relative to age and comorbidities, these patients are also at risk for heart failure, coronary artery disease, cerebral vascular disease, and peripheral vascular disease. Complicating the risk of cardiovascular disease is also the risk of hyperlipidemia. As I mentioned earlier, sirolimus, or it's also called rapamune, and prednisone both can cause elevated lipids, elevated triglycerides. The lipid target goals for patients with kidney disease is we want their total cholesterol to be less than 200, their LDLs to be less than 100, their HDLs to be greater than 50, and their triglycerides to be less than 150. Statin drugs are often prescribed to control hyperlipidemia, but some statins have interactions with some of the immunosuppressive medications like tacrolimus and rapamune, and it can alter the therapeutic level of the immunosuppressive medication. So anytime there's a statin added, we need to not only make sure we're monitoring liver function tests, but also make sure that we're monitoring their immunosuppressive drug levels. And if we need to make an adjustment there, we can. Cardiovascular disease may be part of the cause or a result of the kidney disease. Most premature deaths occurring in the late post-transplant period can be directly or indirectly attributed to events that led to kidney failure and the consequences thereof. So to understand how to prevent post-transplant cardiovascular death and complications, we must identify the etiological risk factors. So this is critical for 3 reasons. First, some risk factors can be modified with therapeutic lifestyle changes or including a daily dose of a baby aspirin. Next, it's important to identify risk factors that can't be conservatively modified. So because risk factors help to identify high-risk patients who can be targeted for screening or perhaps revascularization. And then lastly, there is a strong evidence that intervention improves survival. So who can do this? Nurses, of course. Nurses are frequently able to identify those risk factors that can be modified, and we nurses are in the best position to carry out both screening and interventions. Just as the nursing process evolves, we can continue to screen patients for new evidence of cardiovascular disease. Remember that the patient is the same person after transplant that they were before transplant. So it is quite likely that the patient has the same problems that he or she had before transplant, whether it be diabetes, high blood pressure, hyperlipidemia, as well as any potential issues with medication adherence. To improve the patient's survival, we aggressively have to treat these problems as well as any immunosuppressant-related cardiovascular complications. Oh, my 2 favorite to talk about in both recipients and donors, smoking and obesity, modifiable risk factors for cardiovascular disease. There are numerous studies in the general population showing that cigarettes or e-cigarettes or vaping is an important modifiable risk factor for cardiovascular disease, and smoking unfortunately is prevalent in this kidney transplant population. And if you're in a state like I am, North Carolina, not quite as prevalent as it was in the past, but certainly more prevalent than a lot of states. There was a time it was considered an absolute contraindication to transplant because it is modifiable, and it also because it's difficulty for many patients to completely stop. Studies also show that cigarette smoking is linked to cardiovascular disease in post-transplant patients. Similarly, obesity is very common due to medications, unhealthy pre-transplant diet, sedentary lifestyle. It's associated with inferior long-term cardiac outcomes post-transplant. And as I said earlier, this is certainly something that comes up in living donor world as well. At my center, we require potential living donors to completely stop smoking, and we have a pretty strict BMI cutoff as far as obesity goes before we'll allow them to undergo a surgery. But this is something we have to work in collaboration with patients and the interdisciplinary team to help patients become non-smokers and to maintain that and to maintain a healthy weight, because smoking and obesity are deadly by themselves, but these are both modifiable. So on the brighter side of long-term health considerations, let's look at the non-complicated health that most transplant patients can enjoy. A return to normal function and health is the whole point of kidney transplant. So the interdisciplinary team is responsible for helping the patient attain and maintain their new normal, taking into account modifications necessary to prevent rejection and infection. Preventing any infection of any type is critical, but it requires extra precautions in this, especially when we were in the pandemic. That was of higher consideration, but we also need to make sure that we're following that outside of that situation. We partner with our patients to make a lifetime commitment to healthcare and the necessity of lifetime immunosuppressive medications. they need to be meticulously adherent to their prescribed therapy, as well as assuming habits of wellness, including prevention, getting their recommended vaccines, getting their age-appropriate cancer screenings when those are due, and other therapeutic lifestyle changes such as no smoking and following a healthy diet. A return to wellness also means resuming sexual activity and possibly birth control, which is a question for patients to explore with their nephrologists. The risks in each patient must be weighed, as with any woman taking hormones of any sort, but the ability to conceive is a very real benefit of transplant. However, like every other physiological function, pregnancy must be viewed through a post-transplant lens and considering modifications of both anatomy and physiology. Patients can have successful pregnancy after transplantation. It is possible, but not all transplant programs recommend it. And any pregnancy after transplant is considered a high-risk pregnancy. So programs usually encourage patients to wait at least 1 year after transplant before conceiving, and to make sure that they discuss that with their nephrologist, as there are certain medications that may need to be altered pre-pregnancy in order for a better outcome. Fertility usually does return after the transplant, and pregnancies, like I said, must be carefully planned. There are medications that are given to transplant patients that can be harmful to a fetus. So we need to make sure that those are removed and replaced with something that is safer when helping a patient plan for a post-transplant pregnancy. Of course, like I said, this is considered a high-risk pregnancy and needs to be followed by a high-risk obstetrician. As having and raising children becomes an option, so does returning to work full-time. So with this return of health and normal activity, there can be some changes in family dynamics, relationships that have developed as a result of living with a debilitating chronic illness, and that's no longer the case. So this recovery from illness may precipitate some role reversals from dependency to independence, and patients may struggle with body image changes or have sexual concerns. Also, very frequently, patients share economic concerns such as the cost of their copays, medications, the follow-up that they are required to have. But the interdisciplinary team, especially the transplant social worker, is a great resource for vocational rehab, employment issues, and informational state and local financial assistance programs. Another reality that the patient and the interdisciplinary team deal with are ongoing concerns about potential graft failure and a return to dialysis or a need for retransplantation. Many patients who experience transplant failure will return to dialysis with the hope of another transplant because the new normal that they've experienced is worth it. So transplant is very complex kidney replacement therapy, but an expert interdisciplinary team partners with the patient to manage these issues, and counseling or psychiatric support is available as indicated. And you, as the nurses who care for our patients in other settings, are our partners too. We know that transplant patients' complex regimens to maintain health may be unfamiliar to you, but please contact the transplant team for your patient if there's any questions you have. Be assured also that the most long-term transplant patients themselves are the experts in their own care. So they know that the rigorous self-care is their health insurance. So we also know that there are times when patients need both your help and ours. So there are special populations due to their immunocompromised state, and it's important for patients and caregivers to recognize that problems can arise, and they should recognize those early and contact us and seek help. It's usually not a good idea to wait and see if something gets better when you're a post-transplant patient. If there's any evidence of an infection or other complication, the transplant team needs to know right away. Infection, cardiovascular events are two of the leading causes of death in transplant patients. So while many patients lead a very independent, productive life, Illness cannot be ignored, so early medical attention is critical. So in the early post-transplant period, discharge planning and post-hospitalization monitoring are extremely important in the long-term survival of the transplanted organ. So patient education must focus on these symptoms. We want to make sure that we can address something with early intervention that may prevent a small problem turning into a bigger problem. Patients and their caregivers must access the support of the transplant team when the patient is experiencing things like a fever, a temperature of higher than 101 degrees, or between 100 and 100.9 for more than 24 hours. The transplant team wants to know. If they develop pain or tenderness over their new kidney, or if they develop drainage out of their incision, if it's still early stages, or redness at that site, we want to know about it right away. If they're retaining fluid, if they gain more than 3 pounds in a 24-hour period, or they have lower extremity edema, we want to know about that. If all of a sudden their urine output drops or decreases, or they start having symptoms like pain or burning when they urinate, these are all very important things to let the transplant team be aware of so that we can address it. A UTI in a fresh post-transplant patient can be devastating if not caught early. Even in the long term, there are symptoms that the transplant team needs to be made aware of if a patient experiences, because all of our patients are immunosuppressed and they are susceptible to infections. So we want them to call us and let us know if they have flu-like symptoms, if they have a cough, sore throat, shortness of breath. Of course, in this age of COVID, we're still making patients check for that as well. So any of these respiratory type symptoms we want to hear about. Vomiting. We need to know if they're having vomiting, nausea, if they're not able to keep down their medications or keep down fluids, then they are harming that kidney. So we need to know if that continues for a period of time. Same with diarrhea. If they have that for more than 24 hours, we worry about dehydration. So we need to know that they're going to contact us and let us assess what's going on. Certainly, if they see blood in their urine or stool, we want to make sure that we hear about it. And if they have an increase in their blood pressure, we want to make sure that that is being addressed, because we may need to adjust some of their medications, especially a patient who is on blood pressure medicine prior to transplant. When I had a patient once, so was on 5 antihypertensive medications when he was a dialysis patient. And then he got a successful kidney transplant. And some of those medicines were adjusted, but as the weeks and months went on and that kidney really picked up and started functioning for him, he kept noticing his blood pressure got lower and lower and lower. And that's because he now had a functioning, healthy kidney helping regulate that blood pressure. So he didn't need all 5 blood pressure medicines or as high a dose of some of those medications. So it's something that we make sure that patients are aware of, certainly if their blood pressure is going higher, because that can cause, of course, some complications, but also to let us know if that blood pressure is dropping. So in summary, I hope this module has presented you with a lot of information about the process and the care of both the donor and the recipient of a kidney transplant. The points in summary are that transplant is the superior kidney replacement therapy in terms of quality and quantity of life for the suitable patient. Less than 1 in 5 patients wanting a kidney will get one because we just don't have enough donor kidneys to meet the demand. Living kidney donation is safe and has somewhat better outcomes for the recipient in the short term, but deceased donor kidneys are still needed and also do very well. So whether it be a living donor or a deceased donor, we need more kidney donors. All transplant patients are immunosuppressed and therefore they're all susceptible to infection. Transplant patients often have multiple comorbidities such as cardiovascular disease and diabetes. And so just because they've received a transplant doesn't mean we forget about those. It just means that we add transplant patient to that list to that problem list, and we're addressing all of them, and they're very intertwined with transplant. By definition, all transplant patients do have a stage of chronic kidney disease. It is not a cure for kidney disease. It is just putting them with a better functioning kidney. So we do still have to take into consideration the chronic kidney disease care of patients. With proper care, return of kidney function means a return to a normal life for patients with transplant. Transplant is truly the gift of life. When Rita, in this picture, needed a kidney, her 25-year-old son, Tony, insisted on giving her one because he said, because you gave me life, you don't have the right to deny me the ability to do for you what you did for me. And it's stories like that that really make transplant such an enjoyable and rewarding aspect of nephrology nursing. I've been lucky enough to be in transplant for over 23 years now and can't possibly think of doing anything else. Of course, there are times when the outcomes are not great, but those are way fewer than the times that we see people return to a normal active life and are excited to be back, as they say, back in the real world again. This was CKD Module 5. Again, as a reminder, we have several modules about chronic kidney disease and kidney replacement therapies, as well as palliative care and end-of-life care, and those are listed here on your screen. Okay, well, I'd like to thank everybody for participating tonight and taking the time out to learn more about transplant, and certainly thank you for the care you give our patients that have kidney failure, kidney disease, and choosing to learn more about them and their therapies through these modules. So thank you very much, and everyone have a good evening.